Hello, I'm Dr. Collins, and in this concept video, based on request, we will together create a table that gives you a quick and reliable way of differentiating between upper and lower respiratory tract infections. Differentiating between these two types of infections is quite important because it totally alters the management, as one is self-limiting and the other one would require antibiotics and potentially even further investigations and intervention. So here's our table. We will discover step by step the key differences between upper and lower respiratory tract infections. Let's start with anatomy. Upper respiratory tract infections involve structures above the vocal cords, whereas lower respiratory tract infections involve structures below the vocal cords. Even though there is a plethora of structures above and below the vocal cords, we are talking about a couple of very specific conditions when we document upper respiratory tract infection or lower respiratory tract infection on patient notes. For upper respiratory tract infections, these are namely common cold and pharyngitis, and pneumonia and bronchitis for lower respiratory tract infections. For example, acute tonsillitis or acute sinusitis are also technically upper respiratory tract infections. However, we don't document them as upper respiratory tract infections. We just exactly record them as we think, either acute tonsillitis or acute sinusitis, because these conditions can be bacterial and might require antibiotics as well. For example, for acute tonsillitis, we use a criteria called CENTOR to decide whether antibiotics are needed or not, for which you can find one of our quick mnemonic videos to help you with your smart learning. Similarly, acute sinusitis has a very distinct way of presenting, and depending on how long it has been, we may consider prescribing antibiotics, so it is best to spell it out. On the other hand, there are several other conditions other than bronchitis and pneumonia that can also affect lower respiratory tract below the vocal cords, such as infective or non-infective exacerbations of asthma or COPD. But then again, if we suspect anything other than bronchitis or pneumonia, we spell it out because, again, the management would be different. In clinical context, when a patient first presents to you, the easiest way to distinguish between upper and lower respiratory tract infections is to look at the cluster of the presenting complaint. If the patient's main complaints are sneezing, loss of sense of smell or taste, or a hoarse voice, runny nose, loads of congestion, you're looking at a picture of upper respiratory tract infection. But if the initial presenting complaint is more like a chesty cough with loads of mucus coming up with some associated chest discomfort, you're looking at a lower respiratory tract infection. Once you identify the pattern, the cluster of the symptoms, which should already give you plenty of clues as to what the diagnosis will likely be, you can further hone in some key differences to really confirm your diagnosis. In upper respiratory tract infections, the cough is really either dry or tickly, not a lot of mucus is coming. If there is a bit of mucus, it's clear phlegm. Whereas in lower respiratory tract infections, you're having productive cough with lots of usually colored phlegm coming out. In upper respiratory tract infections, there's usually no breathlessness. Sometimes patients get confused not being able to breathe through their nose as breathlessness, but it is important to distinguish that. In lower respiratory tract infections, people actually might feel breathless. With upper respiratory tract infections, there is no chest pain, but with lower respiratory tract infections, patients might get what we call a pleuritic type of chest pain, which is worse when you take a deep breath in. In the absence of all the other infective signs like a productive cough and temperatures, a pleuritic chest pain, remember, is a very important red flag that should also make you think about pulmonary embolism. In upper respiratory tract infections, there is a lot of runny nose and mucus around the face, which we call coryza, congestion around the upper respiratory tract. But with lower respiratory tract infections, this is largely absent. They are having mucus, but it's coming when they cough. And finally, in upper respiratory tract infections, if there is fever, it's usually mild grade. In lower respiratory tract infections, the fever might be high grade. Once you have completed your history taking, you proceed to your examinations. In upper respiratory tract infections, you're not going to find a whole lot. What you're trying to do is to prove to yourself that there isn't anything bacterial. In upper respiratory tract infections, infections, you will see a lot of coryza, some runny nose, perhaps some conjunctivitis. The throat will be erythematous, but there won't be any pus on the tonsils to suggest acute tonsillitis. The patient wouldn't be systemically unwell. So the upper respiratory tract infection examination would be largely normal. On the other hand, the lower respiratory tract infections will reveal significant examination findings. You might find crackles or bronchial breathing or reduced air entry. On chest examination, the oxygen saturations might be low, the temperatures might be quite high, and the patient might actually look unwell. And in older patients, remember to always think about the CURB-65 score. If the patient is looking confused, having high respiratory rates, their blood pressure is dropping, and they're above the age of 65, you might be thinking about a lower respiratory tract infection progressing to sepsis. They might need more serious intervention during the management stage. In terms of investigations, you would not be doing a lot of investigations, but a lot of safety netting. Remember, any upper respiratory tract infections, if the patient has weakened immunity and the infection is lasting a long time, can result in secondary lower respiratory tract infections. Whereas in the lower respiratory tract infections, if you have found significant chest findings, you might want to follow up the patient with a chest x-ray, especially if they're reporting cough for over 6 weeks, or if they reported that they're coughing up blood, or if they have had significant foreign travel, you might want to send some sputum. And again, as part of the CURB-65 score in the hospital, UNEs might help with the urea, but this wouldn't be something you would typically do in a community setting. So, in terms of management, as we already mentioned, upper respiratory tract infections would be managed with supportive approaches. And once again, remember, a big part of the upper respiratory tract infection management is safety netting. The management of lower respiratory tract infections will depend on the severity of the case. They can be managed with antibiotics in the community. If the CURB-65 score is quite high, or you are worried about the patient that they might not be able to cope well at home, you might consider admission. Thanks for watching. If you like this video, please like and subscribe to fuel the passion to create more videos. And don't forget to check out our other clinical concept videos in our channel. Good luck!